السلام عليكم. تتواضع. نبدأ الآن. باقي تقريبا دقيقتين. بالتأكيد رتب الأمور. السلام عليكم، الله يعطيكم العافية. بسم الله والصلاة والسلام على رسول الله. راح نبدأ اليوم إن شاء الله محاضرة ال NDR. يعطيكم العافية على الحضور والتسجيل على المحاضرة القيمة إن شاء الله والمهمة اللي راح تكون مهمة للجميع، للهيلث بروفيشنال and the community overall. بسم الله والصلاة والسلام على رسول الله. It's been an honor to be with you, among with you at this second time to speak and regarding to the very precious topic, which is talking about the antimicrobial, that precious kind of medication for treating infectious disease. It's very important to preserve this kind of medication and protect them from any misusing or abusing, because we have limited amount of this sort of medication. In this course and this part of course time, the outline of this course is we are going to talk about the microorganisms, various types of antimicrobial, and what is misusing of antibiotics and principle of antibiotics, benefit and risk of antibiotics, and also enable to describe how to manage the infection. And then we start up to speak about various types of antibiotics. We are going to concentrate in this lecture to antibiotics rather than antiviruses or antifungal and antibiotics. So we are going to talk about the beta-lactams and microlides, aminoglycosides, fluoroquinolones, and other antibiotics. So now we are going to talk about what is the microorganism. The microorganism is also known as microbes, are microbic living organisms that has very small size, and that we can't see it in naked eye. They are found in virtually and everywhere in air, and include air, water, soil, and within other organisms. Microorganisms can be classified into several groups, include bacteria, fungi, protozoa, viruses. So the bacteria are single shapes of organism without nucleus. They are diverse and can be found in various shapes, cocci and bacilli. Bacteria can be beneficial and involved in nutrient recycling and food production, and also can be harmful for human and can cause diseases such as tuberculosis or pneumonia. The microorganism is too small to see with eyes. Diverse range of organisms, probiotic was found everywhere, and mostly very helpful, and only small percentage can cause diseases. And you can see in this slide a microscopic picture that show in the red in the orange color the bacteria showing the test. So antimicrobial, it's as we said, it's classified as antibiotic against bacteria. For example, here for the medicines we use in various type of infections, such as urinary tract infection, pneumonia, and cellulitis. Antiviruses against viruses for the medications that you be using for herpes and HIV and Ebola. Antiparasitic against parasites, the medicines that use for malaria, and antifungal, the medication to treat the candida vaginal thrice, and vaginal thrice or thrice in the skin. So the viruses are not non-lethal infectious agents that consist of genetic material, DNA or RNA. The virus is surrounded by protein, coated by protein. They cannot reproduce or carry out the metabolic processes on their own, and depend on the host cell to replicate. Viruses can be infect all types of organisms, include animals, plants, and bacteria, and can cause a wide range of microorganisms play crucial roles in various ecological processes, including nutrient cycling, decomposition, and symbiotic relationships. And they also have a significant impact on human health, agriculture, and industry as well. Scientists continue to study the microorganism to better understand their living that can they work on to invent antimicrobial to treat the infection. So when we talk about the antibiotics, we have to considering where they come from. We need to have a bit appreciation of the history of antibiotic development, because if we consider it before the antibiotics since the 1930 up to 1940, that age is known the pre-antibiotic age. It's dark age indeed, because the people can be died from simple infections, maybe can die from eye infections because there is no treatment for that the infection at that age until 1940. So at the previous age, which is the pre-antibiotic age, the Chinese use treatment. They choose treatment for infection, moldy soil point to cure that treat infection, and ancient Egyptian rubbed moldy bread on wound to cure them, and in Russia. They was using the warm soil was using in Russia by to cure infected wounds. Until 1928, Fleming discovered penicillin, and the first patient started to treat penicillin the first patient was treated with penicillin in 1941. That's an overview of what is the antimicrobial and what the history of antibiotics. Before we start what is the misusing of antibiotics, we have to know what the feature of antibiotics. The antibiotics has a feature like selective toxicity. Every antibiotic drugs kills pathogen without damaging the host. The antibiotics have therapeutic index, which is the ratio between toxic dose and the therapeutic dose. And the less toxic has the less toxic indication in that regard. Of course, it has a huge therapeutic index. Also, the antibacterial action, which is bactericidal and bactericidal. The misusing of antibiotics is referred to the inappropriate or unnecessarily use of these medications, which can contribute in development of the antibiotic resistance and other negative consequences. Here we have some common form of misusing of antibiotics, especially at this time of year. There is misusing between the virus infection and bacterial infection when you talk about the common cold. So the first thing is offer prescription of antibiotics. Sometimes prescribe the condition for conditions that don't need or require antibiotics, such as viral infection, like common cold or flu. The antibiotics are only effective against bacterial infections. Using them unnecessarily for viral illnesses is ineffective and can contribute to the antibiotic resistance. The other thing is incomplete treatment. When the individuals do not complete the full course of the antibiotics as prescribed by a physician, and also here the pharmacists have very important role to insist and make sure to inform the patient to complete the full course of the antibiotics. It can lead to incomplete eradication of the bacteria, and some people stop taking antibiotics once they start feeling better. And when we select the appropriate medication for the sort of infection, the patient has to have improvement in his health within 48 hours. And some people, once they're feeling better, they stop, and that can develop the resistance of to the medication. Also, the self-medication, obtaining antibiotics without prescription. And here the MOH and the health professional have, they insist about not prescribe or taking any antibiotics without a prescription. So the self-medication, obtaining antibiotic without prescription or using leftover antibiotics from previous treatment is the form of the self-medication. This practice is very dangerous, and it can lead to incorrect self-diagnosis or inappropriate treatment, and that essentially lead to maybe can develop the resistance. The other thing is the using antibiotics for non-bacterial infection. Antibiotics are ineffective against viral infections and common cold or muscular and bronchitis. Using this antibiotics to treat these conditions not provide the benefits, but also contribute to the development to antibiotics. The misusing of antibiotics is significant global health and concern because it can reduce the effectiveness of these medications and making it hard to treat bacterial infection, and that can lead to take a longer time to treat the infection. It's hard to treat a bacterial infection and potentially leading to the more several. To combat antibiotic resistance, it's crucial to use the antibiotics responsibly and only when used necessary under the guidance by healthcare professional. One of my preferred for this slide is mind me principle. Mind me principle. When we look at this slide, it's a principle around the antibiotic use. That idea that whenever possible, use the microbiology guide to select the antibiotic. We will come back quite a bit when we start looking at the antibiotic initiated to treat infection. We will take an example for that one. Certainly, we need the evidence based on everything when we use the antibiotic. So the evidence base is very important. The evidence base, the guideline for various types of medical conditions, such as the guideline for UTI, communicable pneumonia, and hospital pneumonia, that's based on the evidence base. So they develop the guideline in according to that evidence. So the other thing is trying to use the narrowest spectrum as we can possible. But in that one, it doesn't mean we always narrow spectrum possible. So sometimes we need to use the broader spectrum, especially when we talk about the severe illness patient. The doctor usually start with a very broad antibiotics to eradicate most common positive organisms. When you talk about the minimized duration of therapy, it's not that not to minimize. I prefer to use the appropriate duration to eradicate the causes of organisms. For minimizing duration, when it's not appropriate, that can lead to an increased risk of developing resistance and increased risk to recurrent infection. Ensuring monotherapy in most situations, that's when we use the guideline usually guide us to take the monotherapy, especially for the mild infection. So they prefer, for example, here we talk about the communicable pneumonia, the mild communicable. It's the first line treatment is it will be monotherapy of antibiotics. We prone to go to the combination of things when the patient got severe infection, and we start to take a combination of that one. What's the benefits and the risk of antibiotics? In this slide, we are talking about the benefits of it's very clear to antibiotics, and it's very important. Once we get infection, we have to treat it as soon as possible. So the benefit for the antibiotics is to eradicate the causes of organisms to cure illness. And the risk is one of the risk is getting a complication of the infection, the risk of antibiotic spectrum related, such as disturbing of natural flora, and that can cause Clostridium difficile overgrowth. The last thing is resistance and the drug class specific allergic reaction, nephrotoxicity, and photosensitivity. So as we said, the benefit of risk of antibiotics, where weighting things up, is the benefit overweight the risk, and when you see the risk overweight the benefit. In this case of the antibiotics, the benefit is clear to eradicate causative organisms. Uh, Causing the infection. In the most part of there's some other instance where we're doing something different than that. But the most part is the benefit is clear to eradicate the cause. We are when we're talking about the pharmacist point of view, when we talk about the consolation, the patient, when when going to consult the patient, he's taking the antibiotic. The typical answer is we will not going to speak about the resistance. We have to consult the patient about the benefit, taking the duration, taking the full medication for full period of time, and ensure the patient understands the medication before going out to their home. So the pharmacist here is play very important role to counseling the patient. Also, pharmacists have to consult the patient who is on antibiotic about any side effect or allergic reaction, especially when we're talking about the penicillin. It's very common to get a reaction for too many people. And to speak with them if they have any side effect after taking the antibiotics, especially for the broad spectrum antibiotics. So disturbing natural flora in gastric intestinal tract, that's producing mild diarrhea and can go to the produce more severe diarrhea and cause the antibiotic associated colitis and can cause overgrowth of Clostridium difficile. So we have this section of natural flora predictable for the broader antibiotic spectrum, and we use we use the more likely the same natural flora for the patient who take for longer course. For patients take the antibiotics for a long time, it's more likely to get the state of natural flora. So the colostrum deficit overgrowth is as considered as a consequences of using broad spectrum of antibiotics. And now we see also for risk of antibiotics other things like oral thrush and for women in vaginal thrush as a consequences of the disturbing natural flora, and all this all entirely predictable based on antibiotic spectrum, and obviously we have to concern about the resistance. Also, there is other risks which are much more about the drug class. Some of them to explain based on the pharmacology, or some of them we are not fully understand in cause affairs. but the most risk of the antibiotic is mostly predictable. So in this slide, we are going to talk about the diagnosis of the infection. What the sign of infection? Depends on the size and the severity of infection, like in local redness, swelling, pus, and cough, and shortness of the breath. If the systemic being involved, that means the patient gets severe infection. Uh, for example, here, fever, heart rate, and blood pressure, respiratory rate, and mental illness. For mental illness, especially when we talk about the elderly people, one of the sign of infection of the UTI, for example, here, for elderly people, is get hallucination, and that consider maybe a sign so the patient has to go to the hospital and check if there is any infection. Of course, the laboratory test to indicate what the causative organism that can cause infection, and that takes time. So usually we start to empirical therapy as a empirical therapy to treat the most common causative organism. Microbial culture, swab, urine and stool, blood, and CSF. There is also organism-specific test, PCR for antigen, and white blood cells that can tell us the patient has infection or not. For the management of infection, this is an overview to tell you how the infection to be managed. The first question is, does the patient have an infection present? In order, we suspected this patient has infection. Maybe he got fever and other signs of infection. So we suspected this patient has infection, and then the answer may be no. And that what we use is a prophylaxis. Prophylaxis that using antibiotic to prevent healthy person for becoming unwell. That's very different. Risk and benefit considers treating someone like that. For example, for prophylaxis here for recurrent UTI. But the time when we have someone we think has infection got the sign and symptom, for the first question is the causative organism. And the most part of the time when the patient is present to the doctor, when the sign and symptom of infection, the causative organism is not known yet. So they don't have the result of those pathogen tests. So in most part, the initial treatment based on we don't know the causative organism, and so that we refer to the empirical therapy. In empirical therapy, what we're doing is choosing the antibiotics that cover most likely causative organism. So we know when we have the particular type of infection, our evidence and our experience to tell us one of the number of organisms likely we're going to choose the antibiotic. So we know that the coverage of the antibiotics and the most and if for example have UTI, the most common or uncomplicated UTI, the most common organism, for example, is E. coli. So we know which the antibiotics can cover that organism and to treat the patient empirically until we got the result. So to choose the antibiotic that cover the most likely positive organism, not going to cover all the organisms probably. So one of the risks of empirical therapy is to make it not work because the infection on the patient may be caused by something that's less common and maybe antibiotic is not covered. So it's very important to monitor the patient when you start the antibiotics. If there is no improvement within 48 hours, is to move on to other common organism until we get the lab result and see what kind of microorganism that caused the infection. The limitation that to be aware of, so in the empirical therapy, we try to use the broad spectrum of antibiotics as we can because we don't know what is the organism. So let's cover everything. The problem is running the risk of building resistance of antibiotics and getting the side effect. But in the reality, most people, they have infection that caused by most likely organisms. So the limitation of the empirical therapy, we don't know the causative organisms. So we usually go to the broad spectrum and that can build the resistance and then also get the side effect of the broader spectrum, like disturb the natural flora, and that maybe eventually go to the cholesterol in that as well. So the empirical therapy does not necessarily mean very broad. We just try to cover the most likely organism. Once we know what the organism is, then we go to the directed therapy. So we know that what is the organism in directed and what the sensitive. We can choosing the antibiotic-based inter-result sensitivity and become much more accurate of the drug choice. And then maybe we choose the broad spectrum after identified because it might be the organism is only sensitive to the broad spectrum of antibiotics. So the broad spectrum, maybe we can choose it in the directed therapy. But the other time we can choose the narrow spectrum as we can, as we follow the mind-meal principle. As we can on the bugs and can choose the narrow spectrum. And obviously we need to think about the drug toxicity in decision making. In terms of the empirical therapy, when we think that start up and we don't know the organisms, yes, we're gonna cover the most likely organism. So we choose the antibiotics that have the spectrum to cover most likely organism. And remember, there is a chance that it could be caused by something else and maybe not sensitive to the antibiotic. And if that case, the patient is not going to respond to the antibiotic. Here is the management of the infection that we talk about. So the empirical therapy is how is the empirical therapy chosen when we know the initial site of infection based on the site of the infection, where the infection site originated. So then we know the common causative organism to that site of infection. We're going to give an example with Dr. Nasmiya in UTI. And also we have an example here how to select the most appropriate antibiotic. We will quickly talk about the pneumonia and how we select the most appropriate antibiotic as empirical therapy. Also, if the site of infection, if it comes from the foreign organism like dog bite, we know the most common organism, so we start the empirical therapy to cover that thing. Also, when we have to bear in mind when choosing the empirical therapy, we have to ask the patient where has the patient been, traveling overseas or in the hospital. If the patient in the hospital, which department in hospital, if in an ICU or intensive care unit, they tend to get the resistance to many antibiotics. So we want to take a broader spectrum and most intensive medication, most intensive management. So we choose a combination of maybe of broad spectrum. The other one here is if the patient has immunocompromised as well. He, the patient who got immunocompromised, he prone to get the huge type of bacteria. So we tend to give him very broad spectrum to cover too many types of organisms. So now we are going to talk about antibacterial drugs, the various type of classification. And bacteria has too many types and classified in regarding to their mechanism of action. So inhibit bacterial cells, beta-lactams, penicillin, cephalosporin, carbapenem, amonobactam, vancomycin, uh, inhibits proteins, microline, for example, azithromycin, erythromycin, or clarithromycin, chlorine-cliniciol, aminoglycoside, and tetracycline, such as doxycycline. Inhibit nucleic acid synthesis, chlorine-quinolone, rifampicin, inhibitor of the metabolic pathway, folate antagonists, such as sulfonamide, trimethoprim, cotrimoxazole. Before we start up, before we go to the next slide, if there is any question, please type it down, and we can then after that we can start to the in details about the antibiotics. If they do have any question. Before we start up to speaking about in details of antibiotics. There is no question. So we start up for the beta-lactams, and this one is very important class. Beta-lactams are a class of antibiotics that include penicillin, cephalosporin, monobactam, and carbapenems. They are named for their characteristic beta-lactam structure, which is essential for the antimicrobial activity. Beta-lactams are worked by inhibit the synthesis of bacterial cell walls which is necessary for survival and integrity of the bacterial cell. They do this by binding to the inhibit enzyme called penicillin binding protein, which are involved in cross-linking of peptide glycan chain in the cell wall. This interference with the cell wall synthesis weakens the bacterial cell wall, and that eventually leading to the to cell lysis and death. Penicillin, such as amoxicillin, augmentin, ampicillin, piperacillin, tazobactam. Penicillin is classified by aminopenicillin, anti-staphylococcal penicillin, and natural penicillin. So aminopenicillin is amoxicillin, classic acid, percillin, and piperacillin, tazobactam. Anti-staphylococcal penicillin, glucoxacillin, digoxacillin, and the natural penicillin is penicillin G and penicillin PK. Penicillin are among the most commonly prescribed antibiotics and are effective against a wide range of bacterial infections. Cephalosporin like cephaloxime, ceftriaxone are structurally related to the penicillin. So what we have to bear in mind when we use the penicillin, it's contraindicated with the history of immediate reactions such as anaphylaxis, bronchospasm, and so the penicillin is contraindicated for patient has history of immediate reaction. So here it's very important to ask the patient and to take the patient medical history to ensure that there is no allergic reaction when they especially when we talk about the pediatric patient. In renal, in environment high parenteral doses and or prolonged maybe result to electrolyte disturbance when you use them, and that's not for the severely patient sick. It's not that we're looking at. Maybe we can just follow up and monitor the patient closely. And also can cause nephrotoxicity due to the accumulation of the penicillin. Here we talk about the high and prolonged dose of penicillin. And the other thing is the risk of neutropenia may be increased. For common adverse effects of the penicillin are generally water-related, diarrhea and nausea. And for diarrhea, we have to be bear in mind about because when we talk about the broad spectrum antibiotic, as you said, it can disturb the natural flora and eventually can cause very serious, especially when the patient taken the medication with no under the health professional. Pain and inflammation at the site of infection that can cause the penicillin, less common with the benzodiazepine. Superinfection includes candida, especially during the prolonged treatment with the broad spectrum. And what's very important for the penicillin is allergy. When we speak about the comparative information, the spectrum, those with moderate and broad with anti-pseudomonal spectrum have additional and an increased activity against gram negative. The nerve spectrum actively primarily against gram-positive organism and usually susceptible to be beta-lactams and usually inactive against enterococcus due to low tissue concentration. Moderate spectrum, amoxicillin and ampicillin are interchangeable. However, there is no oral ampicillin or oral product. They are inactive by beta-lactamase and are active against listeria, gram-negative cocci, for example, in meningitis, and some gram-negative bacilli. For example, non-beta-lactams producing H. influenza, as well as many E. coli, Salmonella, and Shigella. For broad spectrum, adding clavulanic acid. So, amoxicillin is considered moderate spectrum. Adding the clavulanic acid that give the medication broader spectrum. Adding the clavulanic acid to the amoxicillin or tazobactam to piperacillin extend their spectrum of activity to cover many beta-lactamase producers gram-positive and gram-negative. With the clavulanic acid amoxicillin spectrum include species such as coli and Capsicilla. With tazobactam, the piperacillin is active against Pseudomonas and Capsicilla pneumonia. Administration advice when we talk about penicillin is to avoid rapid IV administration for large doses, as they may result in seizures. IV penicillin are physically and chemically incompatible with many substances, including aminoglycosides. So we have to give them separately. For practice point for the health professional, monitor the complete blood count and renal and hepatic function during the prolonged high dose of treatment. When we talk about prolonged treatment, we talk about more than 10 days. Avoid penicillin and cephalosporin when suspected CAPPM probe organism suspected or probe. Enterobacteria that produce in New Delhi methyl-beta-lactamase and Capsicilla pneumonia and carbapenem are often able to hydrolyze beta-lactams and beta-lactamase inhibitors. These organisms are multi-drug resistant, but generally remaining susceptible to the colistin and tigacycline. So the second thing is cephalosporin, such as here cephaloxime and ceftriaxone, are structurally related to the penicillin and are often used as alternative when the patient is allergic to the penicillin. When we said allergic to the penicillin, we talk about delayed allergic, not immediate, because we talk about for immediate reaction for patient with penicillin. That means we cannot use the beta-lactams. We have to avoid them. So, for example, for cephalosporin is ceftriaxone, ceftriaxone, cefuroxime, ceftazidime, cefepime. So the mode of action of cephalosporin is interfere with bacterial cell wall peptide glycan synthesis, as like penicillin, because they are, both of them are considered beta-lactamase group. Binding to the penicillin binding protein, essentially leading to cell lysis and Indication of cephalosporin are rarely for drug first line, so we usually not see them as a first line selection. Uh, we do have an exception, includes cefazidime and cefidime, infebrile neutropenia, and cefalexime and ceftriaxone with benzyl penicillin for the empirical treatment of bacterial meningitis. For precaution, the cephalosporin is contraindicated with patient who has allergy to the cephalosporin or of immediate anaphylaxis or severe hypersensitivity from penicillin, as we said. So we have to be careful when taking this medication. We have to fully understand the patient in front of us, and if we don't know the history of patient, maybe we when they taking this medication, we have to closely monitor them and closely monitor any sign of reaction. Ceftriaxone and ceftriaxone. Ceftriaxone is not preferred to the ceftriaxone is preferred to the ceftriaxone for gram-negative septicemia in neonatal, as the ceftriaxone can displace the bilirubin from albumin, and that may increase the risk of bilirubin encephalopathy. Consequently, it is contraindicated in preterm neonate up to post-menstrual age of 41 weeks, and full-term neonate within jaundice or other conditions that may affect bilirubin binding. For carbapenem, such as imipenem and meropenem and etrapenem, are broad-spectrum antibiotics that are often reserved for severe infections when the antibiotic have failed. So we usually in the hospital we put a restriction for this kind of medication because we reserve it for the intensive care unit as empirical, but we restricted them in other departments of the hospital for not severely infected patient until we got the lab result and sensitive for this kind of medication. We reserve it for the severe illness patient. The mode of action of this medication is like the penicillin, is inhibits bacterial cell wall synthesis by binding penicillin and binding protein. The precaution, the treatment with valproate, sodium valproate, avoid combination with valproate. The concentration maybe can greatly decrease. For practice point of using the carbapenem are particularly useful when the single agent treatment is required for a complex mixed infection. Pseudomonas aeruginosa may develop resistance quickly, resistance to etrapenem. Etrapenem contain approximately 6 millimole, approximately about 137 milligram of sodium. So we have to bear in mind for the patient has any other condition that can, or maybe the patient got restricted of sodium or something like that. Imipenem is given with cholesterol to prevent inactivation by renal dehydropeptidase. Imipenem should be infused 250 to 500 milligram doses over 2 to 30 minutes, and 1 gram dose over 40 to 60 minutes. More slowly if the nausea and vomiting occur. So that's the practice point of carbapenem. The other thing is tetracycline. Tetracycline has a broad spectrum activity that includes chlamydia, mycoplasma, and many others. Derivatives, for example, tetracycline and monocycline are more convenient when you compare them with tetracycline and used more often than tetracycline. Tetracycline used as alternative therapy for early syphilis or gonorrhea in penicillin allergic patients. We use them with caution in the pregnancy, and in some parts of pregnancy, it will be contraindicated as they have a huge adverse effect and a huge drug interaction. IV doses of tetracycline offer 2 gram per day, 2 milligram per day, 2 grams, sorry, per day, and pregnancy may be associated with the fatal hepatotoxicity. So we are going through the pneumonia as quickly overview, and we've taken an example here to show that how we appropriately select the antibiotic as empirical. So if you have looked at the pneumonia as an example, we look typically bacterial infection involves the lung, typically in here in the lower part of the lung. When we made someone describe the left lower lobe pneumonia, and that means the pneumonia at this point in this part of lung in the lower lobe. So if we think about the community-acquired pneumonia, we're talking about the infections was contracted or infections being picked up from community, or the patient is being not in the hospital, or the patient in the hospital for less than 48 hours. Because if they been in hospital for less than 48 hours, they want it picked up in the infection in the hospital. They might be picked up from something they come in the hospital with. So in terms of the causative organism, we really to broad classification of the organism that cause the cat. We have typical organism for cat and atypical organism. For the typical, that's the most common organism that can cause cat. We have typical organism and atypical organism. If we have talking about the typical organism, the strep pneumonia and the hemophilic influenza, and both of these described as a typical organism. And then we have typical pneumonia. These microorganisms we have to be familiar with because when the antibiotic therapy will be in the part related to these organism classification. So what the atypical organism is mycoplasma pneumonia, chlamydia, and Ebola, and we have to understand the causal pathogen and sensitive pattern are very important for guide empirical therapy. So here in this slide, we're showing the amoxicillin, for example. It will be covered strep pneumonia and H influenza, which are considered typical organisms for not severely ill patients. So if we take this antibiotics as monotherapy as empirical for outpatient treatment, uh, maybe this one consider appropriate selection to cover the most common organisms. When we look at doxycycline, in other hand, we see it covers the typical and some of the atypical organism when we roll out Regilla. Uh, and but we got here in doxycycline any a resistance when we talk about streptoneumon. So the amoxicillin is here covering the typical causes of organism, and if we look into the doxycycline, it covers atypical organism. And so the question here is, would the patient has low severity pneumonia, or for the management when we select the amoxicillin, we cover the typical. When we select the doxy, we cover atypical and some of atypical organisms. So in this slide, when we spoke about the penicillin ajú, we may see someone who has a delayed reaction to the penicillin, and we can see here that ciprofloxacin is considered as a second line treatment of choice, and considered as alternative medication, as it has a different site of chain chemistry. So if we see here, we use ciprofloxacin as alternative for delays, not immediate. And when we look at this slide and we see the doxycycline, can see the risk particular class of this medication. We know that doxycycline is prone to binding the medulla complex, and that's not going to be absorbed. So it's prone to binding the medulla complex and will making a complex that's not going to be absorbed. So we do not take the doxycycline with some medications such as anti-acid and iron, and we take them separately. And also, doxycycline can cause photosensitivity, so we have to be careful, and can cause esophageal ulceration. So, taking with the full glass of water and remaining upright is very important. Very important and very important from pharmacist point of view to inform the patient and consult them and explain how they use this medication. So the risk of doxycycline here is photosensitivity, and we have to consult the patient to avoid active skin exposure to the sun, and using the sun screen when they are on this medication. And also, the doxycycline can cause tooth discoloration. Especially for children less than and it can be used in pregnancy during the first 18 weeks of a pregnancy. After that, they are contraindicated as they may discolor the baby teeth and consider at that time of pregnancy is considered as in category D. So in terms of microlife, for example, here azithromycin and clarithromycin, erythromycin, roxicop, promycin. Um, Microlife, there is a potential risk. They have a potential risk of in regarding to the QT prolongation. We just need to be careful about that. And the other thing with macrolides is drug interaction. We can see the significant list of the drug interaction with macrolides, especially with when you're talking about erythromycin and the clarithromycin, because they have inhibit the CYP3A4 and also inhibit BGB that can be involved with azithromycin as well. So erythromycin and clarithromycin has a huge drug interaction as they inhibit the CYP3A4 and inhibit the BGB. But the azithromycin, it's not inhibit the CYP3A4, but can be involved in inhibit BGP in the body. Because of that, azithromycin is considered a preferred choice in various guidelines. This slide is a comparative between the azithromycin and erythromycin in chemical structure, as this site of chemical chain that can inhibit the BGB. When we see that erythromycin has very large and complex compound that can involve to inhibit CYP3A4 and that reduce the drug interaction. So we have to be careful when we use the antimicrobial. Maybe the patient got other medication, and again we have to consult the patient what the medication the patient on, and if there is any drug interaction, inform them and speak with the physician and select the most appropriate antibiotic for this sort of patient. We have a question here. Someone who asked, there is no rule for the augmentin in the cap. Of course, it has very important role, but we're talking about the mild patient who has a mild infection, and the amoxicillin alone can cover the most common organism as empirical therapy. Some physicians go to the augmentin as a broader spectrum, but if we use the amoxicillin alone, it can be covered the most causative organism. And we have to be aware about that patient if has an improvement of uh, improvement within 48 hours. We just got a very quick overview about the cat. So the augmentin is one of the drugs of choice. If there's any other question, you can write them down and we can explain about that. Maybe we can take a few, 15 minutes as a break, and then we start up to the other antibiotic before we go prayer break if, for 15 or 20 minutes, and then start up again. Thank you very much. الله يعطيك العافية. صوت واضح؟ لا احنا اخذنا بريك بس ابو 20 دقيقة عشان خلاص. طيب we have spoke about microlide and penicillin and tetracycline and we talked about uh, the most common adverse effect and most common causes of organ and we went through for the simple infection of pneumonia and how to manage it and what the most common organism that can cause the cat. And now we and also we explain the different type of microlife. And now we move on to the vancomycin. And vancomycin can be involved, especially for when we talk about MRSA and for example pneumonia. For pneumonia, when the vancomycin being involved, especially for hospital-acquired pneumonia, because as empirical before we get the culture. So the vancomycin is the mode of action is the bactericide that inhibits the bacterial cell wall synthesis by preventing formation of protein. The indication of vancomycin is due to the incidence of clinical isolate resistance to the vancomycin, for example, vancomycin resistance. Some countries adopted that guideline to use the vancomycin. Vancomycin considered in our hospital as restricted for intensive care unit, especially when we suspected the MRSA. And also, we restricted this medication because we need to follow up the renal function. And the pharmacist and physician have to work hand in hand to follow the patient who on this medication, especially when the patient taking this medication for more than 48 hours. We have to follow the renal function, and we have to doing the TPM to follow up the medication concentration and select the most appropriate dose. Vancomycin is used for treatment of serious infection caused by susceptible organism resistance to penicillin, MRSA, and MRSE in people with a serious allergy to the penicillin. Also, vancomycin can be used for Clostridium associated disease. Some physician maybe can use vancomycin as oral when the patient not responsible to the other medications of antibiotics. We know that vancomycin, the bioavailability of this medication when taken orally is very, very low. So the physician, they prescribe the oral vancomycin. They tend to treat the infection in the gastric. So the bioavailability of the vancomycin orally is very low, so it will not go to the concentration will not go in the systemic circulation. So, but it can be used orally for some cases. Used for antibacterial prophylaxis for endocarditis before certain procedures in the penicillin hypersensitive people at high risk. Used for surgical prophylaxis for major procedures involving implementation of, for example, cardiac and vascular procedure in some situation with high risk of MRSA or MRSA. Well, the precaution we have for vancomycin is serious allergy to particular glyphosate contraindicated. Here in environment for many that maybe increase the risk with vancomycin as can cause ototoxicity from fungi. Treating the patient with combined with aminoglycoside can increase the risk of ototoxicity and nephrotoxicity. So the patient is on the vancomycin and aminoglycoside. We have to closely monitoring this patient, especially for renal function and ototoxic. In renal treatment with nephrotoxicity again, such as what we commonly see the aminoglycoside with vancomycin maybe increase the risk. And as we say, we have to monitor the renal function and drug concentration. So the vancomycin is very important to follow the concentration of the vancomycin and doing the TDM of this kind of medication. Concentration monitoring when given with aminoglycoside or other nephrotoxic drugs, where the pharmacokinetic are, for example, for burn patient or morbidly obese may require high doses due to the large volume of distribution. Here we talk about the pharmacokinetic of maybe can be changed with people, obese people, and burn patient, and that can alter the vancomycin concentration. Also, we have to monitor for during the high dose of vancomycin and for patients who are using this medication for a very long time. In patient who has hemodialysis, receiving vancomycin can be infrequent dose. Vancomycin can change the half-life and varies according to the ultrafiltration rate and dialysis board size. For therapeutic range of vancomycin, the trough liter should be from 10 to 20 mg per liter. Taking the first sample just before the fourth dose. A trough more than 10 mg per liter minimize the resistance, but maybe increase the risk of nephrotoxicity. So we have to closely monitoring by the pharmacist and the physician, especially when the patient is been using with any other medication can cause nephrotoxic. For area under the plasma concentration, to minimum individual concentration, that can measure the vancomycin concentration and useful method to predict the vancomycin efficacy when treating this indication with a serious infected patient. In the practice point of vancomycin, give over at least 60 minutes. The vancomycin. Beta-lactams prefer to treat susceptible staphylococcus aureus infection, as a vancomycin may be less effective. Aminoglycoside, the aminoglycoside, for example, for this medication, amikacin and gentamicin, streptomycin, the mode of action of this medication is inhibit protein synthesis by irreversible bind to the ribosomal subunit and causing the cell membrane damage. This medication is concentration dependent bactericidal effect. So the efficacy it will be effective when we get the appropriate concentration in the body to eradicate the causes of organisms. Aminoglycoside also can cause the nephrotoxicity and ototoxicity, especially when the risk will be increased, especially if we get in this medication with other medications such as vancomycin, as we said, that increases risk. And again, because it's very important, we have to closely monitoring the patient and closely monitoring the concentration of this medication to give and eradicate and treat the infection appropriately without causing any side effects. So if we got the high concentration of this medication, that can be damage the kidney, and we got another problem for the patient. So that's the role of pharmacists to follow up the result of the lab result and calculate the concentration for vancomycin and aminoglycoside and monitoring the patient result and the duration of taking this medication. So the precaution is relatively similar to vancomycin. Ototoxicity maybe can cause contraindicated in people with history of vestibular or vestibular toxicity caused by aminoglycoside. Renal impairment increased risk of toxicity due to higher plasma concentration. As we said before, the aminoglycoside is concentration-related treatment. The risk factor of nephrotoxicity include length of treatment, high plasma concentration, and also dehydration and treatment with other nephrotoxic drugs. In elderly people, use with caution as there is more likely to be pre-existing renal or renal impairment. Children decrease the dose in neonate as a half-life of this medication can be prolonged. In pregnancy, for aminoglycoside, use the amikacin and gentamicin or tubramycin in pregnancy does not appear to be associated with an increased risk of malformation, most experienced with the gentamicin. Some cases of renal abnormality have been reported when the gentamicin was used with the ciprofloxacin and corticosteroid in the first trimester. So we have to be aware of this and avoid this medication during that time of pregnancy. Here's the comparative between the aminoglycoside and regarding to the risk factor of ototoxicity and nephrotoxicity. We can see the gentamicin has relatively, when you compare to the other regarding to the amikacin regarding to the other, it's less risk of ototoxicity compared to the streptomycin, for example. However, the streptomycin is less than the other regarding to the nephrotoxicity of this indication side effect. However, the gentamicin is one of the most choice in the hospital acquired gram-negative infections. So this the schedule here can give us an overview of aminoglycoside and comparative information. It's very useful. We need to compare between them and regarding to the risk of side effects. For the concentration monitoring, for the patient treating less than 48 hours, we don't need to monitor the concentration, but we do that if the patient using this medication more than 48 hours. Aminoglycoside in our hospital is considered one of the restricted as well for more than 48 hours. So after 48 hours, we need a justification why we are going to continue, and the justification can give us alarming about renal function. So the doctor and pharmacist has to follow and monitoring the medication concentration closely to avoid any renal damage. So the treatment within more than 48 hours, measuring the drug concentrating and monitoring the serum creatinine every 3 to 5 days in a clinically stable patient. Obtain the result daily. The clinical, especially for renal function, is unstable. If the renal function is unstable, if we do have an alternative, we're considering using the alternative agent. The next one is fluoroquinolone. For example, here for ciprofloxacin, moxifloxacin, and norfloxacin and ofloxacin. Some of them is concentration-related treatment, and so the treatment is dependent on the concentration. Moxifloxacin, for example, here we're not using for UTI as it's not concentrated in the urine, and it's not recommended. The fluoroquinolones are highly effective antibiotics with many advantages of pharmacokinetic properties, include high oral bioavailability and large volume of distribution, and give us a broad spectrum antimicrobial activity. Antimicrobial resistance to fluoroquinolones has grown. Fluoroquinolones carry a risk of serious adverse effects such as Clostridium difficile and tendinopathy and neuropathy, and have a multiple drug interaction. Therefore, the fluoroquinolones used is typically reserved for cases in which the benefit clearly outweighs the risk. And also we have uh, uh, to follow up the patient using this kind of indication. The spectrum of activity, mechanism of action, and resistance, important resistance pattern, and the adverse effect are commonly available for fluoroquinolones such as ciprofloxacin and levofloxacin and moxifloxacin. The fluoroquinolones is we use it as a restricted antibiotic for uncomplicated infection. As the risk outweighs the benefits, so for uncomplicated infection, we not prefer to use the fluoroquinolones because the risk here is overweight the benefits. Such as uncomplicated cystitis and UTI or acute bronchitis. We use the other antibiotics that has well tolerated and has less side effect. So the indication of the quinolones is reserved for broken or suspected infection where the alternative agents are ineffective or contraindicated. For example, here complicated UTI. So as I said, we not recommended to use the quinolones in uncomplicated infection. We use it also in bone or joint infection, prostatitis, and here we notice that the worldwide resistance to quinolones has been increased. So we have to be cautious about that. And we have, as a pharmacist, work hand in hand with the physician to select the most appropriate antibiotics before we start treating the infection. So the precautions of quinolones is the neurological quinolones are associated with the serious neurological adverse effect, peripheral neuropathy, which is maybe irreversible. So we have to avoid use chronic quinolones with people with history of peripheral neuropathy. They may induce the seizures in people with epilepsy or history of CNS disorder, and if possible, to avoid the combination with other drugs that may increase the risk of seizures. We have to avoid the quinolones in some cases, such as MG, as they worsen muscles weakness, include the respiratory muscles. Tendon damage. Used cautiously if there is a history of tendon damage from quinolones. So here the taking patient history, medication history is very important, and important to report any side effect that can cause from any medication, include antibiotics such as quinolones or penicillin. So if the patient has a history of tendon damage from quinolones, we have to recommend alternative if it's possible, and monitor the patient closely. For corticosteroid and the fluoroquinolones used for patient age more than 60 years old, that also can increase the tendon damage. So we have to bear in mind about that adverse effect and inform the physician and the patient about that. In children, damaging to grown cartilage has not been demonstrated in human and due to the criminals use at similar rate in comparative groups. Criminals are not recommended for use in children and adolescents, only in severe infection where the benefit outweighs the risk. For example, here, febrile leukemia, Pseudomonas aeruginosa infection, and cystic fibrosis. In pregnancy, we are not recommended fluoroquinolones based on the potential effect of the developing cartilage. However, there is available data do not suggest that an increased risk of abnormalities. So, reserved for severe or life, reserved and restricted this indication for severe or life-threatening infection for which safer drugs are inappropriate. So, for infectious disease, we have also weighting things up. We have to weigh the benefit and weigh the risk. If the benefit outweighs the risk, we have to select the medication, even though the patient has a side effect or maybe can cause or increase the abnormality. So the other thing is rifampicin, rifabutine, and rifampicin and rifaximin. The mode of action of this sort of a group inhibits bacterial RNA, and rifampicin and rifabutine are bactericidal against rapidly divided tuberculosis and active against those which are semi-dormant intracellular organisms. Rifaximin has a local effect on E. coli that cause traveler diarrhea on GI flora that produce toxin that cause encephalopathy. For pregnancy, rifampicin is considered safe during the pregnancy, one of the drugs recommended to treat TB during pregnancy. However, use it in the last few weeks of a pregnancy. We have to give a prophylactic vitamin K to the mother and the neonate as bleeding attributable to the hypoproteinemia has been reported in a newborn and in mother and after the use of rifampicin in a later pregnancy. So in rifampicin, it's considered safe during a pregnancy, but we have to be cautious during the third trimester of pregnancy. We have to give with the vitamin, with the rifampicin vitamin K to reduce the risk of bleeding. The other antibacterial can we speak with is linezolid, and linezolid is considered alternative medication for vancomycin when we talking about MRSA.